amputation is to prepare a residual limb for a prosthetic device. Amputations are cut on an average 5 to 7 inches below the knee to allow for a prosthetic device to be properly fitted. A limb that is cut too short could cause a prosthetic device to be improperly fitted. However, if a limb is cut too long, the patient could suffer from circulation issues. Another measure that is taken to make sure the limb is properly cut is the fibula is cut a half an inch shorter than the tibia to create a round surface instead of a more square surface for a prosthetist to work with when creating a device. The two major muscles that are involved in shaping a residual limb are the soleus and gastrocnemius, both innervated by the tibial nerve. When the amputation is occurring, both muscles are severed and shaved down so that they can be wrapped around the anterior portion of the tibia and attached to the anterior side. This provides a cushion and creates a better shape for the prosthetist to work with when forming a prosthetic device for the limb. Other muscles such as the tibialis anterior, fibrialis longaris, and extensor digitorum longus are cut and attached to small holes drilled in the anterior and posterior side of the tibia. The blood vessels in the residual limb are clamped shut in order to prevent bleeding. After the damaged tissue has been removed, the flaps of skin are immediately shut in most amputations. However, if a patient has a high risk of infection, the flaps of skin could be left open in order to decrease their risk of getting an infection. Before a patient can be fitted with a prosthetic device, they must first overcome the high possibility of attaining edema. Edema is a swelling of a residual limb due to accumulations of fluids. Edema is treated using rigid dressings and shrinker socks.
So I'm going to talk about some of the arthrokinematics as well as the osteokinematics of the tibiofemoral joint. So the osteokinematics of the tibiofemoral joint are knee flexion, knee extension, as well as partial medial rotation and partial lateral rotation. So the arthrokinematic motions during knee flexion are the concave tibial plateaus moving on the convex femur condyles. So as the knee is flexing, the tibial plateaus are moving posteriorly on the femur condyles. And then during knee extension, the concave tibial plateaus are moving anteriorly on the femur condyles. So these arthrokinematics are evident during open chain exercises such as hamstring curls or quadricep curls. It is different during a closed chain exercise such as squatting because the femur is now moving on the tibia. So as you're moving towards mid-squat, your convex femur condyles are moving on a concave tibial plateau. As you're moving from your mid-squat to your end squat, your convex femur condyles are still moving on the concave tibial plateaus.
The first step towards an actual prosthesis is a preparatory prosthesis, which is used for several weeks to months until the limb is stable enough for a final prosthesis. The final prosthesis consists of a socket, shank, foot and ankle, a foot shell, and various liners and socks. The socket is the most essential part of the prosthesis. The socket is first formed using plaster or a CAD/CAM scanner. This mold of the patient's limb is then transformed into a test socket. Once the correct modifications have been made to the final socket can then be configured, but only when the socket is comfortable and functional for the patient. When considering how to make a patient's socket, you must consider their level of activity. If they are highly active, layers of carbon fiber may be added. The same goes for patients who are heavier in weight and need more support. The next part of the prosthesis is the shank, which takes the place of the structural bones of the lower leg, the tibia and fibula. There are numerous types of feet and ankle available for patients. Main factors to consider when choosing a foot or ankle is its durability, weight, function, energy return, flexibility, shock pylons, torsion adapters, and maintenance. Patients with a low-level activity need a foot and ankle as a largely cosmetic function, while highly active patients require a foot and ankle that mimic a normal foot while walking or running. This ankle and foot needs to act as a shock absorber, adapt to terrain, provide a smooth rollover from heel to toe, and provide rigid lever for propelling forward when you finish your step. When using your prosthesis, it must always be taken off at night before you go to bed, and it needs to be examined for any type of damage. Patients must also examine their limb for any sign of irritation or blisters. The prosthesis should always be cleaned regularly to avoid bacteria buildup. Also, proper exercises recommended by the patient's physical therapist should be performed regularly. Finally, the prosthesis needs to be kept in great shape for the patient relies on it to perform everyday activities.